So Hanya, without further ado, thank you very much.
Thank you very much. Thank you. And it's really a pleasure to be here after such a nice welcome. I really appreciate it very much. It's always a privilege to be invited. I always feel honored and privileged. And it's not an exception. It's not my first visit to South Africa. I visited South Africa at least 4 times, and I always enjoy it very much. So once again, thanks a lot for this kind invitation. You already know that my scientific heart belongs to a number of scientific organizations, and ESPEGAN is definitely one of them, and ISAP, International Scientific Associations for Probiotics and Prebiotics, is also among those. So this is a topic of my presentation, functional gastrointestinal disorders in early life. Where are we now after ROM4 criteria? And I have to change the style because, as a matter of fact, the more correct title is disorders of the gut-brain interaction in early life. And why I'm changing it, I mean, those two terms are being used interchangeably. However, more and more disorders of gut-brain interaction is preferred term. But both terms are used interchangeably, and it will be probably used also during this presentation, but I will come back to it also later on. So what I would like to discuss, there were 4 parts of my presentation. ROM4 criteria, what are they and why are they important? I will talk about some debates in pediatrics regarding functional gastrointestinal disorders. What are the discussions and what are the differing viewpoints? Because they are very different viewpoints, as you will hear. I will talk very briefly about ROM5 criteria. What can we anticipate even with limited information? They are top secret. None of my friends who are contributing to it, they don't want to say anything about it. But still, we will try to anticipate what it will be in ROM5 criteria. And finally, I will talk a little bit about my most recent lover, which is artificial intelligence. I have to say it's a kind of love that is not returned. It happens with love at first. But I will talk about artificial intelligence and how technology is shaping the future generally of medicine, and a little bit about functional gastrointestinal disorders. So this is what I want to cover in my presentation, and I will start with ROM4 criteria. What are they and why are they important? So what are the ROM4 criteria? Well, I tried to summarize it very briefly. These are symptoms-based diagnosis and no need for tests. So this is probably the simplest, the shortest definition of ROM4 criteria. And there are adult criteria and pediatric criteria, and they are also divided within the pediatric group for those in children up to 4 years of age and older children and adolescents. The 3 most frequent functional gastrointestinal disorders in infants are, of course, regurgitation, infant colic, and constipation. And I was asked to talk about those functional gastrointestinal disorders in early life. And this will be covered in my presentation. And also one of the reasons is that 1 in 6 families will consult a health professional. So they will consult you, and I already learned there is increasing number of this consultation. So I will not go into all the details of ROM4 criteria, but still I would like to highlight some what is in those criteria. So for example, infant regurgitation, what is important is the age is given here, but also the time frame. For 3 weeks, the symptoms have to be for 3 weeks or more. And it's very common for those, I would say it's for all criteria, that time frame of symptoms is very precisely given. For infant colic, my comment is that there are different criteria for clinical purposes, for everyday life, and for clinical research purposes. And why there are different criteria, it's very easy to explain. If you look for research purposes, it's a crying or fasting for 3 or more hours per day for 3 or more days in 7 days. So if an infant is crying just for 2.5 hours, according to those criteria, you cannot make a diagnosis. And in clinical, in real life, you will not, of course, you will not wait for 3 hours for at least 3 days. So that's why there are different criteria for clinical purposes and for research purposes. But for research purposes, it's extremely important that we follow those criteria, because then we can compare different interventions or to see what are the effect sizes in different interventions. So that's why it's important to have different criteria for clinical purposes and research purposes. And again, time frame of symptoms is given as previously. And for functional constipation, again, there are criteria given and the age is given. And also there are different criteria in toilet-trained and in non-toilet-trained children. So again, are very specific, but again, they are really symptom-based, and time frame is given. So I just highlighted some of those criteria, but I have a question to you. Do you use the ROM4 criteria in your daily practice? And I know by experience that some of you, very few, are really using it in everyday practice, but many are not using it, despite that they are published, they are available, etc. So what are the reasons? What are the challenges? So the first is that symptoms often overlap with other conditions. I will discuss it later on. There are time constraints in busy clinical settings, and also we have to rely on accurate patient symptom reporting. And it's not always so accurate. If you ask mothers, I'm sure that in your country it's exactly the same. Well, it's very difficult to define what is the duration, the exact duration of symptoms, how many days, etc. And in addition, for example, for regurgitation, we have this very solid, very robust criteria, but very often just speeding and feeding issues. For infant colic, very often it does not fulfill the criteria. It's just crying, these are just crying and sleeping problems. For constipation, it's hardly ever that those infants will meet the ROM4 criteria. It's just hard stools or straining. And it's not so well covered in ROM4 criteria. So there are some challenges. And this brings me, after this brief summarizing what are the ROM4 criteria, to the next part of my presentation, which are debates in pediatrics. So I will cover what are the discussion and different viewpoints of functional gastrointestinal disorders, and there are many. And I will provide you some arguments for and some arguments against. So let me start with the first one, which is the clinical recognition. So functional gastrointestinal disorders are globally recognized by ROM4 criteria, which provide clear guidelines for diagnosis. And I already showed you, at least for those 3 most common, but for others, there are also very clear criteria. But there is also an argument against is diagnostic uncertainty. Symptoms such as excessive crying and regurgitation can be vague, subjective, often overlapping with other conditions or normal development stages, leading to concern about overdiagnosis. There's a lot of discussion about overdiagnosis of certain conditions, including functional gastrointestinal disorder, or, for example, cow's milk allergy, because the symptoms very much overlap. And this is a very famous paper published in JAMA Pediatrics by Robert Boyle and Daniel Mumblit from UK. And this data comes from each study, one of those studies on early introduction of potentially allergenic foods into the diet. But they also look at symptoms like vomiting, like colic daily. And you will see that, for example, when it comes to confirmed diagnosis of cow's milk allergy, it's just a very small portion of those children. And it's exactly the same with functional gastrointestinal disorders, because those symptoms may also be the symptoms of functional gastrointestinal disorder. So we do have problems with diagnostic uncertainty. What are the other controversies and debates? So symptom burden? Well, there are data showing that functional gastrointestinal disorders cause significant distress, including sleep disturbances and poor feeding, which can impact both infant and also equally important family well-being. You know that now family well-being is equally important to patients' well-being. An argument against is that functional gastrointestinal, so-called functional gastrointestinal disorder may be just normal developmental variability. Some symptoms, such as regurgitation or colic, are common in healthy infants and may resolve on their own as the infant matures. So again, the question of this overdiagnosis. And like with adults, not every adult person who is sad has a depression, and not every infant who is crying has some kind of disease. So we have to be very careful not to overdiagnose those conditions, which may lead to medicalization and over-treatment. And again, I will talk about it. The question is, some of the symptoms just get better over time, and this is exactly with the question, do colic symptoms get better over time? And the answer, yes, we all know about it. By the age of 4 to 5 months, the crying, the colic is already gone. And this is an interesting study which I like to show because you have data from 3 different time frames. Now 1962, 1986 and 2001. And the question is, do babies cry more now? And the answer is no, there is no difference. This is an important study. Maybe we are more sensitive, maybe parents are more sensitive, but the data do not show that they are crying more. Another study which I also like to show, this is a systematic review and meta-analysis and percentile charts. So this percentile-based charts are to define normal versus excessive infant crying. Because when we ask what does it mean, excessive infant crying, I mean, you will find whatever definition you want. And for example, in some countries, crying is not in infants is not considered as anything which is very special. Like for example, in Japan, they don't make the diagnosis of infant colic. It just doesn't exist. Infant may cry, that's fine. I mean, by the age of 4 or 5 months, it will be gone. And it's also true. So it also very much depends on the culture, on the population. What are the other controversies and debates? Long-term consequences. They are an argument for is that functional gastrointestinal disorders in infancy, if unrecognized or untreated, may predispose individuals to problems later in life. And I will show you. And the argument against is, which I already mentioned at least twice, overdiagnosis risk. By classifying normal infant behaviors as functional gastrointestinal disorder, there is a risk of medicalizing conditions that may simply be part of normal growth and development. And I already mentioned it. Over-treatment, over-diagnosis, and medicalization of normal symptoms. So we have to be very careful, and there is a lot of discussions about that. Long-term consequences, together with my friends, Flavia Indre from Italy and Ivan van den Plas from Belgium and some other colleagues, we look at this infant colic and long-term outcomes in children. And you can see there are some studies showing short-term association and medium to long-term outcomes. And this short-term association include maternal depression, child abuse, early breastfeeding cessation, and medium to long-term outcomes include later sleep problems, family dysfunction, and behavioral problems. Child abuse, it's something which is really very frustrating and concerning. This is a study which shows that colic is the strongest risk factor for shaken baby syndrome. So it shows you that it's not just a benign condition, but it may be very problematic condition. But of course, what is important is to remember that all these studies are observational studies. They are showing association. None of these studies will prove causation. There is no way, but we will never have stronger evidence. This is the strongest evidence that we have from observational studies. What else is what is new? This is a recent study published in Allergy on infantile colic, which is associated with the development of later constipation and atopic disorder. The pathomechanism behind it is not very well understood, but perhaps through gut microbiota and disturbances, so-called dysbiosis. I will talk about it in a moment. That might be one of the mechanisms. Again, this is an association. Causality has not been documented. What are the other discussions? On the argument 4, on the pathophysiological basis. Research supports potential mechanisms such as disruptions of gut-brain axis and gut microbiota dysbiosis that may explain functional gastrointestinal disorders in infants. The argument against is that there is lack of objective markers, and diagnosis of those disorders relies on symptom-based reports, which is the strength of RON4 criteria, of course, from parents, but no available biomarkers or imaging tests, making it difficult to confirm these conditions as distinct clinical entities. So what is the strength of RON4 criteria may be also the limitation of RON4 criteria. But let me now focus a little bit on microbiota alterations and functional gastrointestinal disorders in infants and children. And there are many studies which looked at microbiota. This is one of the systematic review which was published relatively recently. Van Vandenplas is the last author. And as you may expect, you will find everything that you want. I mean, you will always find some alterations in the gut microbiota. But there are also some problems because we don't know what exactly defines a healthy gut microbiome. This is one of the most difficult questions to be answered. What are the features of health-associated gut microbiota? This is a very recent paper published in Gut just a few weeks ago. What defines a healthy gut microbiome? And they do not provide, I mean, the exact answer. They are just asking the question, where do we put the line between disease, which is probably the easiest way to make the diagnosis, to this absence of disease, diagnosed disease, but still there are certain symptoms like bloating, like gas, like discomfort, to absence of disease or digestive complaints with a question mark. It may be defense against pathogens, efficient nutrient absorption. And finally, what is the ideal gut structure and function, and what is the optimal microbial composition? And in addition, please remember that each one of us has a completely different gut microbiota. We don't have the same. It's like a fingerprint. So it's important to remember. If there is one feature that I would say which characterizes gut, health-associated gut microbiota is the diversity, except for the first 2 years with a huge dynamic of the changes, but then by the age of, let's say, 2 years, what is characterized for health-associated gut microbiota is a diversity, which matters. What are the other challenges when we are speaking about gut microbiota? There are challenges with the term dysbiosis. This is a term which I'm using very often when we are talking about gut microbiota. This is a publication like 2 or 3 months ago in Gastroenterology. And the challenge is that the term dysbiosis suggests an abnormal microbial community. However, without a clear definition what is normal, it's hard to define what is abnormal. So perhaps the term dysbiosis, it's not the best term to be used, even if at the moment we don't have anything better. And what is also important, that taxonomy doesn't mean function. So it's not only important who is there, but also what is doing for gut microbiota. So you can see, I mean, it's easy to say they are disturbances, they are alteration in gut microbiota, but it's very difficult to understand the meaning and what is the cause and what is the consequence. And I can continue this discussion for a long time, but as you know, the patients do not care about our science. What they want to know is, can we cure them? Can we prevent diseases? And this brings me to the next part of my presentation, and again, there will be some controversies. And this is about treatment. So for functional gastrointestinal disorders, the argument for is that there is a treatment evidence. Interventions such as some probiotics and dietary changes have shown efficacy in reducing symptoms, especially in colic or regurgitation. But the argument against is that the evidence is very uncertain. And many treatments are based on small studies, which is true, with no consensus on the best approach. And you will see on them in the moment. And in some cases, conditions may resolve naturally, making treatment unnecessary. So again, we want to avoid this medicalization over treatment. But still, functional gastrointestinal disorders in early life, they are considered benign, but they are the source of concern and frustration for parents. So they come to us, they want their children to be helped. And I would just show you 2 or 3 documents that were published recently that they will show you that even within the group of experts, they are slightly different opinion. And you know it very well because you are listening to many talks and presentations, etc. So this one was selected because it's co-authored by people who are involved in the Rome 5 criteria. And this comes from Rome Working Group, and it focuses on pediatric aspects of nutrition interventions for disorders of gut-brain interaction. And there are different conditions like regurgitation, colic, or functional constipation. And just to make it easier for you to read, this is, I showed you what are the recommendations. For infant regurgitation, in breastfed infants, elimination of cow's milk from the mother's diet. A non-breasted infant, thickening, additive, or formula, and cow's milk elimination. Not everyone agrees, as you will see in a moment with that, but some people do agree. Infant colic, in breastfed infants, elimination of cow's milk from the mother's diet. Cochrane review, for example, says there is no evidence for that. But this comes from these people who are involved in Rome 4 criteria. So very likely we will find it in Rome 5 criteria. Other elimination diets, probably. In non-breastfed infants, cow's milk elimination, because there is still this discussion whether or not colic may be a symptom of cow's milk allergy. So this was one example how experts, those involved in Rome 4 criteria, what is their understanding of the current literature. What is new? This comes from the Espegan Committee on Nutrition, and this is a recent position paper on infant formula for the treatment of functional gastrointestinal disorder. So my colleagues from the Nutrition Committee are using, like we are using interchangeably, those two terms. Functional gastrointestinal disorder. A quite recent paper, I think it was published like April or May. And it's a long document, it's an open access, so everyone can read it, but I did try to summarize it on one slide. So for breastfed infants with functional gastrointestinal disorder, the recommendation is do not switch from breastfeeding to commercial formulas. General advice for parents is functional gastrointestinal disorders are normal, no need for treatment of special formulas. For regurgitations, consider second anti-reflux formulas in some cases. In another document, when I was still on the Committee on Nutrition, we specified that it's really the recommendation in those with growth failure. So this is an indication. For colic, no strong evidence they work, so slightly different compared to what you will see in a moment. Constipation, consider formulas with high beta palmitate and more magnesium to soften stool. Generally, limited evidence supports the use of specialized formula for functional gastrointestinal disorders, and of course always prefer breastfeeding over formula feeding, but it's clear to everyone here. So this is a very recent position paper from the Espegan Committee on Nutrition. What else do we have? I mean, we also have some experts like Ivan van den Plas, whom I mentioned his name already here at least 2 or 3 times, and he's the co-author of this paper, which was published like I think 2 or 3 years ago. And then you see, for example, for infant colic, there are also recommendations for regurgitation. Avoid overfeeding and overstimulation. consider probiotic if formula fed, but also if formula fed, also you may consider partially hydrolyzed formula, reduced lactose, prebiotics, and follow up for 4 to 8 weeks. So you will see you have different group experts and you will have different recommendations. And then the question is how these poor pediatricians, somewhere in my country, you know, in the small village, how they have to know what to choose. And finally, there is another document which comes from the ESPEGAN Special Interest Group on gut microbiota and modifications. And together with many of my colleagues from ESPEGAN, we published this position paper, and we evaluated various probiotics for various gastrointestinal conditions. And this is a summary of approximately 2 or 3 years of work. So we summarized, and this is summarized on one slide. And you can see there is the first column are those conditions that we evaluated, including some of the functional gastrointestinal disorders. The second column are the strains with positive recommendations. They are in green. The third column in the red, strains which are not recommended. We have enough evidence to say they are not effective. And finally, we have a column, no recommendation for or against, which means there is evidence, but we are not able to make the recommendation one direction or the other direction. But today we are only speaking about functional gastrointestinal disorders in early life, so infant colic, and this is a recommendation from our ESPEGAN document. 2 strains with positive recommendation, L. reuteri DSM 17938 and Bifidobacterium lactis BB12. You know that all these numbers and all these letters which are next to the name of the microorganism are extremely important because they serve like an ID, like a passport for the microorganism. And each strain acts differently. We also provided the dose and the duration of the treatment for the management of infant colic. And what is the effect size? What you can expect when you use probiotics with documented efficacy? This is the effect size, reduction in crying time by 25 to 45 minutes. And then the question is, are you satisfied with this? And should we be treating infant colic at all? And this is a question which it doesn't come from me, it's the editorial in BMJ. And the question is, should we? And I ask you about this 24, 45 minutes per day, and should we be treating, should we be using this probiotic? And my answer is always the same, that scientists or physicians sitting in this beautiful room and parents who have an infant crying at night may be completely different in their opinions, because for some of them, even reducing the crying time by 10 minutes would be something which would make a difference. So this is the evidence, this is the effect size, but interpretation of the evidence by each one of us may be completely different. So I just tried to summarize some of these controversies and some of the debates. There are probably even more, but what we can summarize it by saying, and this comes from George Bernard Shaw, and it was not on functional gastrointestinal disorder, but it applies to it. Science never solves a problem without creating 10 more. And it's very much true also for the topics that we are discussing today. Okay, so I discussed Rome 4 criteria. I discussed some of the debates in pediatrics when it comes to functional gastrointestinal disorders. And now I would like very briefly talk about Rome 5 criteria. What can we anticipate even with limited information? So first of all, this is a change in the terminology. In Rome 4 criteria, there were 2 terms, functional gastrointestinal disorders and, in small letters, disorders of gut-brain interaction. For Rome 5 criteria, as you can see it on the website, it's only disorders of gut-brain interaction. As I already mentioned, everything is top secret. Mark Benningham, Anna Maria Staiano, Carlo Di Lorenzo, no one wants to tell, even during the dinner like that. They don't want to say, they say, well, we cannot say anything, so we have to wait. The criteria are updated every every 6 to 10 years, and their update will be in 2026. This is what they promise. But the question is, what is this gut-brain axis? So people are asking very often, and this is like a bidirectional signaling between what is happening in GI tract and in the brain. And one of the questions which is very often asked is, so how is this communication between the gut and the brain? So how it can be possible? And of course the answer is we don't know. Usually in medicine we don't know how something works. But there are some speculations. So first of all, it might be peripheral serotonin. So there are cells in the gut which produce large quantities of this neurotransmitter serotonin, which may have an effect on signaling on the brain. So this is one of the ways. The second is through the immune system. Through the immune system, because the bacteria, microorganisms which are in our gut, they can prompt immune cells to produce cytokines. They can influence neurophysiology. And when we are saying that not all microorganisms are the same, not all probiotics are the same, this is one of the reasons, because not all of them will have exactly the same effect on immune cells. And that's why this is something that differentiates. And last but not least, there are metabolites. This gut microbiota is like a biochemical factory. They produce hundreds, thousands of various virus metabolites. And these metabolites, such as, for example, butyrate, which is a very good example, can alter the activity of cells in the blood-brain barrier. So this just shows you some of the examples how this communication through different molecules can go between gut-brain and the gut. But we don't know for sure, and there is a lot of work on this crosstalk, and I hope we will. And it's a lot of animal studies, not so much in humans, but a lot of animal studies. As I already mentioned, around 5 criteria which should be available in 2026, and many of my colleagues and some of their papers are presenting, like Mark Beninga, Carlo Di Lorenzo, and many others. They are in this pediatric committee, but they do not want to share anything about it. They keep it secret, which is okay. So, but what we can expect, and these are just my speculation, what can we expect from round 5 compared to round 4? So I think that we can expect more precise diagnosis, like improved accuracy in diagnosing those disorders, updated criteria based on new scientific findings, hopefully. It might be that will be new disorders or more subtypes, like possible addition of will be like in round 4 criteria, that we had some new conditions that were not previously. More specific subtypes, like for example for IBS. Perhaps will be better age group alignment. So these are just my speculations. Of course, as I said, I don't know any details. Well, I know one. And it relates to early life. But I cannot say, because until it's published, it may change. You know how it is with experts. Okay, so I discussed round 4 criteria. I discussed debates in pediatrics. I discussed very briefly round 5 criteria. And now I go to my lover. And my new lover is artificial intelligence. And I would like to tell how technology is shaping the future of everything, I would say, not only a functional gastrointestinal disorder, because whether we like it or not, AI is here and it's here to stay. This is the fact. Nothing will change it. And there is ongoing shift from traditional evidence-based medicine to next generation evidence-based medicine, which is AI-based medicine. And this is for various reasons, with the way we collect data, the way we analyze data, everything is changing very rapidly. And AI is more than ChatGPT. For many of us, AI started with ChatGPT, which means November 2022. For me, it started more or less, I would say, December, January 2023 that I started. And the reason I started to be interested was because I read quite regularly Nature, and it has turned out that on every single day there is something on ChatGPT in Nature. And I thought, if a journal like Nature is addressing ChatGPT every single day, there must be something behind it. So I started to be interested in it. So let me start with just very brief introduction, because those three terms are being used interchangeably. They do not mean exactly the same. So the broadest term is artificial intelligence. And how to define artificial intelligence? I mean, it depends whom you ask, as always. And the artificial, but this comes from one of the EU documents. It's a collection of techniques enabling computers to mimic human abilities. Machine learning, which is just a subset of artificial intelligence, it's a subset of AI techniques that allows algorithms to perform well-defined tasks by learning from data. And this allows them to make predictions without being explicitly programmed. And there is a difference between programming and between machine learning. And I will explain it to you very briefly. Traditional programming is that we have data, we have program, we have like an instructor who tells the computer step by step how to go from A to B. So detailed instructions, programming, instructions written by a programmer. With machine learning, it's a completely different situation. We have data, and we are saying, hi, computer, look at different examples and figure it out yourself. Find patterns. So we are not telling him how to do it step by step. What we are saying, do it yourself. Find a pattern. It might be that the pattern will be exactly what we can see, but it might be that it will be something completely different. For one example is, for example, necrotizing enterocolitis. Many of us are aware that it's probably not a single disease, but many diseases. And now artificial intelligence or machine learning is being used in order to identify different subtypes of necrotizing enterocolitis, because the computer sees it differently compared based on data. And another subset of artificial intelligence, or I should even say a subset of machine learning, is deep learning, which is very much connected with artificial neural networks. Something which those of you who are following, who obtained the Nobel Prize in physics, you will know that those two guys got it for works on artificial neural networks, which started like 25 years ago. By the way, Geoffrey Hinton, one of these Nobel Prize laureate, is quite critical nowadays. He's a little bit worried about what he contributed to. And finally, there is also ChatGPT, which is a subset again of artificial intelligence, or I should say deep learning, of machine learning models that can generate media such as writing, images, or music. How machine learns, because it's very important for us, and I'm not computer scientist, I am not data scientist, I will never be, and none of us will be, but we have to know how to communicate with computer scientists, because without us, they will not do anything. And we, without them, we also will not do anything. So we have to understand it. So how machine learns? They learn exactly how we are learning. So machine learning is like how people learn. It practices and learns from mistake to improve. And this slide shows you all these various steps from getting data to having a model. So you start from machine learning, you start from getting data. You collect as much data as possible. It's not data from 10 patients, not from 100. It's better if you have closer to million than closer to 100. The more data you have, the better they will be, the better you will have a use. You have to clean, you have to prepare the data, like for example, remove duplication. You should have in random order, so it will be not like the first 500,000 will be children with whatever have pneumonia and the other half without pneumonia, because then the computer very quickly will learn that the first 500,000 is pneumonia and the second is not. Train the model. The third step is extremely important. You train the model based on the data. It's like us. We are trained on the books we are reading. If we are only reading 2 books or 1 book, we will be trained, but not very efficiently. If we are trained on 100 books, we will be trained much better. So it's training the model. Then you test the data. What does it mean? You have to see how well the model is performing when he sees data which he has never seen. So let's say you learn from 2 books for your exams in pediatrics. You know everything by heart. You go to the exam, and then you get question from the book which you did not learn, and whether you can still answer or you are not able to answer. So this is testing data, how well you were trained. And then you are not very well, so you improve, and then eventually you have the model which you can use in real life. So this is a machine learning. I don't have such a good example for functional gastrointestinal disorder as I have, for example, here. AI-based model for detecting diseases from eye retinal images. It's clear that if you look at the retina, you can make recognition of eye disorders, but based on these retina models, you can also recognize diseases like stroke, like Parkinson's disease, myocardial infarction. And this is a study carried out in London, in UK, based on 1.6 million images of retina. Can you imagine 1.6? And in addition, it comes from London, so it is a multi-ethnic population. So it's not only a single population, like in my country. We are very, very single ethnic population, so it will be more difficult. But here it's a multi-ethnic population. And I like this, eye can be used as a window to the rest of the body, just the diagnosis based just on the retinal images. But of course we are here. I was invited to talk about functional gastrointestinal disorders, so I'm going back. And for example, we don't know what are the causes of these diseases. Like, for example, we don't know what is the cause of infant colic. And some other people, like clever people in computer science, in data science, they are trying to answer it. Can machine learning uncover the causes of infant colic? So they will be using data from electronic medical record. So this is why it's so important that the data that we put, all these nodes, are as precise as possible, because then machine learning will be based on our nodes, nothing else. So perhaps it will help. There's also another study which was published as an abstract, not as a full. Flavia Indria from Italy is the first author. Can machine learning help identify early risk factors for functional gastrointestinal disorder? It's extremely important for us to identify those children who are likely to develop functional gastrointestinal disorders, because then perhaps those interventions that we are using will be more effective. And this was based on 6,000 data from 6,000 infants, and what was done, even this risk prediction score was presented. It's not published yet. I'm absolutely sure that very soon it will be published. So perhaps we will see whether we can use it in our settings. But please remember, published research, when it comes to AI, when it comes to machine learning, does it equals clinical practice? And this is what you can see. And also, I was in the course on machine learning or artificial intelligence in healthcare. So it was written like that in BMJ 4 years ago and repeated in this course. The vast majority of published clinical prediction models are never used in clinical practice. There is increasing number of abstract and research papers with terms like machine learning, artificial intelligence in the title or in the abstract. But it doesn't mean that it translates into the clinical practice. Many of us are using ChatGPT, and even if you are not using as a physician, Your patients, our patients, are using it. So what does it? ChatGPT is a large language model. Chat, because it's for conversation, you can communicate with us. Generative, because it creates responses. It's pre-trained, it's previously trained on many texts. And transformer is a special type of algorithm. I did not talk about the algorithm, but of course machine learning is based on algorithm. And transformer is a special type of algorithm. And we are using ChatGPT, and our patients are using, and there are many benefits for patient communication, for support diagnosis, for assistance with medical documentation, for treatment recommendations, for administrative tasks, and definitely there are better, faster, more accurate, personalized. But there are also potential risks, which includes error, over-reliance on NI, privacy concerns, and also those of you who are using ChatGPT, you know this term hallucination, that the ChatGPT hallucinates. It creates kind of information. It's always very polite. It always provides an answer, always. There will be, and if you say, well, it's not a correct answer, why, I do apologize, I will try again. It's very human behavior, don't you think? We are also not perfect. And this is a study which was published JAMA Internal Medicine 2023, so last year. Doctors, it was comparison doctors versus ChatGPT. It's, as you can see, empathetic responses, 45% in favor of ChatGPT. High quality responses, 79% in favor of ChatGPT. Preferred responses from ChatGPT, 79%. Well, there are many opportunities when it comes to artificial intelligence, machine learning, but there are also many challenges. I will not discuss all of them, but just very briefly, because I have to finish so that you can eat something. Data, well, data, they are really important. First of all, quality and quantity. Quality, as always, garbage in, garbage out. The quality of the data, I mean, on which the machine learning will be learning, from what we'll be learning, is extremely important. And quantity. One of the very first things which I learned in one of my courses is that the artificial intelligence is data hungry. I really like this expression, data hungry. So the more data they have, 1 million is better than 1,000. That's obvious. So AI models are labeled data hungry. Black box. You probably heard this term. We know the input and then output of an algorithm. They are very well known. But the process by which the algorithm reaches its conclusion is very often not understood or transparent. You may say it's the same in medicine. For example, fecal microbiota transfers. We don't know how they work, but they are extremely effective for recurrent Clostridioides difficile. And there are other examples in medicine. But still, we want to know how the machine, how the computer came from A to B, especially if the machine is making, if the model is making decisions about our, let's say, operation or diagnosis or treatment, etc. Validation, tests and trust. I can repeat it again and again. Test before you trust. It's like with this exam. I mean, you learn from 2 textbooks, you go to the exam, and you have to see whether or not your knowledge is really worth something, that you test in on some data that you have never, seen. It's important. And last but not least, ethics. Well, it's a topic for not even for one seminar, not for one day, and people are discussing it all over the world. This comes from the document, WHO document 2021, but 2 years later, in 2023, there was already updated document because there are so many challenges. But I just want to call your attention to 2 items. One, AI accountability. Who is responsible for AI decisions? And the second, AI autonomy, that humans should keep control over AI. I am not prepared personally to rely on the decision based by AI. And our patients, at least in my countries, are also not prepared. It's changing, of course. But we, at this stage, I think we have to be the one who keep control over AI and be responsible for all the decisions. But no doubt, and this again comes from the course that I attended, no doubt 50 years from now, people will look back and be amazed that we did not have AI in every single domain of healthcare. I think it's not even 50 years. It's much more likely 5, 10 years that we will be very much surprised. And one of the questions that we are asking very often, will artificial intelligence take our jobs? Well, yes. Well, I would say this comes from the president of the American Medical Association. It's clear to me that AI will never replace physicians, but physicians who use AI will replace those who don't. And it's very much true for every profession, I would say, or for many professions. So for AI, well, I'm closer to retirement than starting my career. So very likely AI will not replace me, but I think really that young people really have to learn about AI as much as possible. Okay, so this brings me to my take-home messages. ROM 4 criteria, the gold standard for diagnosis, functional gastrointestinal disorders or disorders of gut-brain interactions. Those two terms were being used interchangeably, but there is room for improvement. I highlighted some of the debates in pediatrics: diagnostic uncertainty, normal variability, overdiagnosis, and often limited evidence for treatment, and also not so very often, as you saw, the recommendations from different societies or different expert groups, they do differ. ROM 5 criteria, expect updates to improve clarity and treatment strategies, including nutritional aspect, but for the moment, top secret, we don't know anything. And last but not least, my new lover, artificial intelligence, is here to stay. I don't know whether he will return my love one day, but more research is needed to address uncertainty. And let me finish by saying a good speech should be like a woman's skirt, long enough to cover the subject and short enough to create interest. I did my best. Thank you very much for your attention.
Thank you so much, Prof, and thank you to the NNIA for bringing her out. We really enjoyed a fantastic talk. Thank you. While everybody is thinking about questions, I have a question maybe for the audience first, and that is how many of you, because most of you I think are in the private sector, so how many of you are using AI to generate reports to the medical aids to request for funding? Nobody. They're all scared that the funders are here, but they're not, I think. Okay.
Can I just comment? I have to say I'm using, for me, it's like an assistant in my work, also in research work. Like, for example, when we are thinking about how to design a clinical trial with our PhD student, it's really like an additional member of the team. It's not better, it's not worse. It's just a different view. And there is a lot of discussion how to use transparently ChatGPT or this kind of tools in writing the grant proposals, writing manuscripts, etc. So it's, I mean, the field is changing very, very rapidly.
Thank you. So if you're not doing it yet, please start.
In my department, everyone is using, and the moment they discover, you know, how it easily can write something, I mean, the next day they just try. So just you have to try, but it's not that difficult. It's easier and easier. You do use probably, yeah.
So maybe just to return to the, I like to say DGBIs because it rolls off the tongue easier, I think. And my question is on the COMIS score and how useful you think it is in practice when you're sitting in front of the parents. And maybe, I'm not sure if all the colleagues are familiar with the COMIS score. Maybe you can introduce it as well.
So COMIS score is a score which was developed for identification of children who has problems with cow's milk. It's not for the, it's like an awareness tool, and it was developed like an awareness tool. It's not for the diagnosis of cow's milk allergy. So if there are some symptoms that may be related to cow's milk allergy, so it's more for cow's milk allergy allergies than for functional gastrointestinal disorders. But I'm still using more often functional the term functional. It can be, well, it's quite useful, I would say, when you want to see what is a response to treatment, like, for example, elimination diet. We are not using it so much for functional gastrointestinal disorders. Do you use it? But perhaps it's also the maybe used, but we are not using it. For cow's milk allergy, response to elimination diet, yes, quite often.
Yeah, so I think that's...
But in one of our trials that we are looking at some of the functional gastrointestinal disorders, we will be using it, by the way, just crossed my mind.
Yeah, so I think it's the same, almost like the Rome 4 criteria. You have to know the symptoms that are going to make you think cow's milk allergy, but you're not going to go through each criterion and add on the score when you're sitting in front of the parents.
But when we are speaking now about cow's milk allergy, I think it's important also to underline that the guidelines changed, and now open oral food challenge is recommended in everyday practice. So it's not double-blind placebo-controlled food challenge. And this is one of few exceptions that guidelines from ESPEGAN are exactly the same as from EAC, European Academy of Allergy and Clinical Immunology, because very often we have guidelines that say something different, which is very confusing.
Thank you. Has anyone thought of questions yet? I know you all sit in front of moms on a daily basis who are at the end of their tether, and I think, for me at least, treating the mom is much more difficult than treating the child. Do you have any suggestions?
Well, for the moment, but this is an extremely important observation, and I think we see it more and more often, that many of those disorders are not really infants' disorders, but really like a perception of mothers or families, parents, as fathers as well. And I mentioned already Japan, and in Japan, infant colic, for example, is not considered as anything to worry about. It's just infants can cry. In my country, if an infant cries for 10 minutes, it's already, you know, everyone is involved. For half an hour, all the physicians in the family. For 2 hours, it's like all... Exactly, or abroad, or physicians abroad are being involved. So it's very much population dependent, culture dependent.
I think we have a question. Oh, yes. I'll come back to you.
It's okay. Do you think, Prof, that we're getting to a point where then we can use AI-generated questionnaires online, of course, for mothers to actually be able to diagnose what FGDs their babies may be having by actually inputting the symptoms themselves before they come and actually ask you, I think my child, well, they're going to tell us my child has colic or has reflux.
Well, I don't think that we need artificial intelligence, because there is a lot of such questionnaires available on the internet that were developed already. But yes, AI may help in predicting, if we develop such tools, in predicting functional gastrointestinal disorder. But the problem is, and I want to highlight it again, that published or available tools do not mean they were validated. So it's extremely important. For example, FDA have only endorsed less than 1,000 devices, AI tools, and this is because not so many of them, and I'm not talking about pediatrics, there's none in pediatrics, mainly in radiology, cardiology, neurology, everything which has something to do with images. So it's very likely that in the future we will have something like that, but it's really important to once we develop such a tool, then it has to be validated, and only then perhaps we can use it. And an important thing is data upon which these models are being trained. Because if they are trained, for example, only in children from South Africa, the question is how well they will perform in my country, for example. And many of those tools are developed or are trained on data from countries like US, I mean, there is where there's the most research, Canada, UK, US, and this is very selected population. And then the question is whether they will be useful in those settings which really need them, because they do not have resources for more sophisticated, imaging techniques or whatever, or tools. So there's a lot of, I would say we are at the beginning. It's very promising, and I really look forward. But every tool that we have, AI tool, machine learning tool, has to be validated according to all the principles that we know. Randomized control trial for intervention, diagnostic tests, we have to see what is the diagnostic validity, etc. But it's happening very quickly, much quicker than when I read about AI, I have the feeling, that if I do not read for 2-3 days, the field has changed so rapidly that I have to start from the scratch.
Thank you very much for the most funky and simplified version of a most difficult topic in infantile period, I will say. I'm a pediatrician in private practice, working in neonatal ICU. All the consequences of gut disorders complicated from the NNU, and then following them up after that. I feel like I'm becoming dystopian in the future, looking forward to that, because my consultation for these topics often turn out to be 2 hours by collecting information and data for those that I see for the first time, that I can make the program forward. I would like to ask you something that is part of this that we didn't cover in this, both of you, the opinions. In a practice today, you see the babies who cry 3 hours, 5 hours, 3 times per week, 1 week, and whatever. They have no evidence of any other diseases. They all on thickened formula, taken off the breast milk, and they all on PPIs and probiotics. I would like you to ask you PPIs and probiotics.
So first of all, can I comment immediately about PPI? There's overuse of probiotics worldwide, but there's also overuse of PPI, which are not recommended, and it's clearly stated in the guidelines. Unfortunately, they are being used, and they contribute to gut disturbances in the gut microbiota, of course. So after reading this paper in gastroenterology, I try to avoid the term dysbiosis, but this is the term that we are using. And they really contribute, and we know that there are some associations, some links with some of the diseases. So, if it's a healthy infant, if it's an infant with infant colic and there's nothing, I would say, just let's try to eliminate those treatments which are not necessary. This is what happens very often in our departments. Our children are coming with a suspicion of cow's milk allergy or a food allergy on various elimination diet. And I have a feeling that what we are doing in the department very often is just trying to introduce normal food, normal diet, which is never very easy. But now it's your turn.
I'm not sure I can add to that, but certainly the PPIs, there's been very good randomized controlled trials in children with reflux and with colic. Doesn't work. And
we have also published, and it's published in Journal of Pediatrics, a systematic review and meta-analysis PPI, and they do not even reduce crying time. So there is no evidence, as you say, to support it. And in addition, there are some harmful effects. And by the age of 4 or 5 months, the symptoms disappear. But the problem is parents, because they think that whatever happens, that they need to treat it. This is a core question about of medicalization of certain symptoms. And that's why many people are against using to be very careful with using any kind of intervention, not to have for parents, so that we do not teach them that whatever happens that you immediately need some kind of treatment. But of course it has to be outweighed, the risk and benefits.
We have another question here, it's online. Trish Hall from Durban, actually Mshlanga, I think, or Belito, more on the north coast. Sorry, let me just get back to the question. And it's actually 2 questions, but they're linked. So she's asking, shouldn't we be considering the term disorders of the gut, brain, and skin? And then she says, will AI link the gut to the brain, to the skin with data from different specialities?
Well, you know, one of the first things which I learned at the course which I attended, which I really liked very much, was that you have to ask a proper question to see whether or not the AI, I am using this broad term, will be able to answer this question. And it has to be very specific, like with any kind of research. And once we formulate this question, the next step is, do we have enough data to answer that question? And perhaps there are other methods, not using AI, not using machine learning, but more traditional that would answer. So it's difficult to give, you know, yes or no, because it's really very much on a very specific, like with every research, we have to know exactly what is the aim of and then to see whether AI tools, machine learning or any other will be helpful. And what kind of data do we have? Do we have enough data for the model to be trained? And if we have enough, what is the quality of the data? So everything that I showed. And then we can probably, hopefully, I mean, I think that many of the questions, but on the other hand, science never solves the problem without creating them more.
And then there's another question, and it is, what is the relationship between the gut and the brain, in summary?
Well, I did show this in summary. I did hope that I showed the simplest slide which was possible to show what are the links, but the simplest answer would be that all these molecules that are being metabolites, which are being produced by various microorganisms, mainly bacteria, like, for example, short-chain fatty acids or cytokine, that they may have an impact on what is happening not only in our gut, also in our parts of our body, but especially in our gut. I really did try to show it on the simplest slide that I can find.
And these slides will be available afterwards for you to go and relook at that. We've got another question online. So the online people are definitely listened very well. And the question is, what is Prof's thoughts on silent reflux? Sorry, I don't have my glasses on, so I am struggling a bit here. On silent reflux and the differentiation between that and colic when there is no spit up as yet. If the PPIs work, why stop it?
You want to answer?
I'm not sure that I fully got that question. So for me, the first important thing to remember is that reflux is normal. We're all refluxing as we're sitting here. And so there are, and you can look at the literature, the studies have shown that changing the pH of the reflux doesn't change the fact that you reflux.
So the take-home message is, please do differentiate reflux from gastroesophageal reflux disease and treat it only if there is a gastroesophageal reflux disease, which is not so common, especially in infants.
And then we've said the PPIs actually don't work. Or do they?
Well, I mean, if you have a reflux disease, it's another story, but it's not so often that you do have reflux disease in infants. It's much more common that we have just reflux, and as you said, it's a common condition.
Okay, I don't have more questions here for the moment, so back to you, Tim.
I think in partial answer to your question was about stopping breastfeeding and changing and chopping formulas, and that's definitely something that's close to my heart, because by the time they come to Ped Gastro, they have been through every single formula on the market. Mom has stopped breastfeeding because she now feels that her breast milk is clearly not good for her baby. That's what we teach them. And I think this is maybe a platform to really advocate for stopping that practice.
Yeah, but there's also another issue, which is this confusing messages from guidelines. The problem is, and it doesn't apply only to functional gastrointestinal disorders, but for many other guidelines, that there's no They differ, and then you go from one physician to another, and they are using different guidelines, and they provide different kinds of information. In this respect, I really like Scandinavian countries in Europe because they discuss for ages, you know, how to deal with certain diseases. So it goes for a long time, but eventually, as a group of professionals, they come to certain conclusion, and it's not that each physician tells something different. And once we are speaking in a same language, it helps parents. And then they are not switching from one formula to another. But this is also a problem. We are, you know, the nation of individualists. So everyone has different opinions. So it's probably the same here.
Yeah, and then I think, Prof, we also see a lot of the time that foods are eliminated and never added back. And I think cow's milk is a good example. Avoiding cow's milk might improve the reflux, but that doesn't mean that it's allergy. Exactly. So.
And I mean, this is another topic, cow's milk allergy, and again, overdiagnosis in some cases, but also underdiagnosis in other cases. So that's why it's so important for cow's milk allergy, for any kind of food allergy, food challenge to confirm the diagnosis. And it's really good that in the guidelines now, it's clearly stated that open oral food challenge is sufficient for making the diagnosis, not for research purposes, not for the difficult cases, but for generally it's. You have another question?
We've got, I think it must be the last question because we've got a few hungry souls here, I'm pretty sure. The question is, will I be correct to recommend L-Reuteride drops to a baby displaying colic symptoms who's displaying colic symptoms on exclusive breastfeeding?
I mean, there's even, I mean, for drops, for Lactobacillus reuteri, this is in line with the ESPEGAN guidelines, so it's a nice conclusion. And yes, indeed, the evidence is better for breastfed infants than for formula-fed infants. Having said that, please remember, we don't have data to show that colic in breastfed infants differs from colic in formula-fed infants. So. Yes, but this is the way. This is the way of manage infant colic.